Hi guys, so now we are going to start breast part 2. In this chapter, we will be discussing lymph node levels, the types of mastectomy, breast conservation surgery, and after that, breast reconstruction. In this chapter, we will be discussing breast cancer follow-up, prognostic factors in relation to CA breast, sentinel lymph node, and then we will be discussing the special types of breast cancer like inflammatory breast cancer in pregnancy, male breast cancer, Paget's disease of nipple, molecular classification of breast cancer, cystosarcoma phyllodes, multi-gene test, and then we will be discussing the comparison of BRCA1, BRCA2, aberrations in normal development and involution, that is ANDI, mastalgia, and at the end we will be discussing breast cyst and breast abscess. So let's start first. See the lymph node levels. So lymph node levels are 3. Lymph node level 1, 2, 3 in relation to one muscle. Can you tell me which muscle? It is pectoralis minor. So see the lymph node levels. Level 1, it is located below and lateral to pectoralis minor. Level 2, it is located behind pectoralis minor. And where is level 3? Medial and above pectoralis minor. Clear? So in this you can see that this is level 1. It is located below and lateral to pectoralis minor. It is further divided into 3. APL. How to remember? APL, Andhra Premier League, mnemonic is Andhra Premier League. So A, that is anterior. This is anterior. P, that is posterior. So anterior, this is posterior, and L, that's lateral. So anterior, posterior, lateral. After that, level 2. What is level 2? Level 2 is located behind pectoralis minor. So level 2, it includes central and interpectoral. What is the other name of interpectoral? Can you tell me? This is Rotter's notes, and this was asked many times. So it is central and interpectoral. The other name of interpectoral, that is known as Rotter's. You can see. Level 2, that is known as Rotter's nodes. That's Rotter's. This is Rotter's. After that, level 3 is here, medial and above pectoralis minor. So you can see level 3 is apical, right? So see the lymph node levels. You can see the muscle pectoralis minor. So level 1, below and lateral to pectoralis minor. So you can see this is level 1. Level 2, it is behind pectoralis minor. So you can see the level 2. And level 3, you can see this is located medial and above pectoralis minor. These are the lymph node levels. Next, we are going to discuss the mastectomy. It is very easy to understand. See, you can see here, suppose this is the breast. Clear? You can see this is the nipple, this is the areola, and imagine this is the mass. This is the mass. What kind of incision is given? We are giving elliptical incision whenever we are performing mastectomy. So you can see this kind of elliptical incision is given, and always we have to include the skin overlying the tumor in the incision. So elliptical incision has been given, and what I'm removing here, you can see, you can see nipple, areola, skin, breast tissue, breast mass. So what is the name of this surgery? This is simple, also known as total mastectomy. Simple or total mastectomy. Apart from simple or total mastectomy, if you remove level 1 lymph node, this is extended mastectomy. Apart from simple mastectomy, if you remove level 1 and level 2 lymph node, it is modified radical mastectomy. And if you remove all 3 lymph node levels 1, 2, 3, simple mastectomy plus removal of level 1, 2, 3 lymph node plus excision of pectoralis major as well as minor, then it is Halsted radical mastectomy, which is also known as radical mastectomy. So you can see here, simple or total mastectomy. This is en bloc removal of nipple, areola, skin, breast tissue, breast mass. Extended mastectomy, this is simple mastectomy plus removal of level 1 lymph node. What is modified radical mastectomy? So here, it is simple mastectomy plus removal of level 1 and level 2 lymph node. Means en bloc removal of nipple, areola, skin, breast tissue, breast mass plus level 1 and level 2 lymph node. After that, you can see Halsted radical mastectomy. So it is en bloc removal of nipple, areola, skin, breast tissue, breast mass plus lymph node levels. Which one? 1, 2, 3 plus 1, 2, 3 plus excision of pectoralis major as well as minor muscle. Important point. Plus excision of, we are going to excise excision of pectoralis major and minor. Pectoralis, pec major. So it is pectoralis major and pectoralis minor. Pec major and pectoralis minor. Clear? Now see, what are the structures paired in Halsted radical mastectomy? And there is a mnemonic. What? ABC is paired. Structures paired. That is ABC. So you can see here ABC, it is paired. What is the full form of ABC? Tell me. A means axillary vein. So this is axillary vein. B means Bell's nerve. That is Bell's Bell's nerve. Can you tell me what is the other name of Bell's nerve? Other name, it is also known as long thoracic nerve. And C means cephalic vein. So C, that is cephalic vein. Bell's nerve, and C, that is cephalic vein. Clear? So axillary vein, Bell's nerve, cephalic vein. Clear? So these are the structures which are spared in Halsted radical mastectomy. Okay. After that, there are special types of mastectomies which are asked. One is extended radical. So apart from radical mastectomy, we are removing internal mammary nodes. And super radical, in super radical, apart from radical mastectomy, we are removing supraclavicular, internal mammary and mediastinal lymph nodes. So how to remember? Easy to remember. Extended radical mastectomy mnemonic is RIM. RIM means radical mastectomy plus removal of IM. IM means internal mammary nodes. IM, that is internal, this is internal mammary nodes. IM, that is internal mammary nodes. Clear? After that, super radical mastectomy. So this is radical mastectomy plus removal of SIM. SIM means SIM. SIM means supraclavicular lymph node, I means internal mammary node, and M means mediastinal. Clear? So it is supraclavicular lymph node, internal mammary nodes, internal mammary. Clear? And M, that is mediastinal. Internal mammary nodes and M, that is mediastinal. Clear? So extended radical and super radical. These are the types of mastectomy. After that, there is another question which is asked frequently. What are the variants of MRM? Variants of modified radical mastectomy. First of all, Auchincloss modification. So Auchincloss modification is same as MRM. It is same. It is same as modified radical mastectomy. So this is same as MRM. After that, Patey's modification. What was the problem with Patey's? Patey's wanted to remove level 3 lymph node. And for removing level 3 lymph node, what he did? He excised pectoralis minor and then he removed level 3. Scannellon's modification, Scannellon told Patey's that rather than going for excision of this pectoralis minor, you can just go for the division of pectoralis minor and then you can remove level 3 and resuture it. So if you go for excision of pectoralis minor, this is known as Patey's modification. If you just go for division of pectoralis minor, this is Scannellon's modification. So see, in Patey's modification, there is en bloc removal of nipple, areola, skin, breast tissue, breast mass plus 1, 2, 3. Extra lymph node is level 3 plus excision of pectoralis minor. Scannellon's modification is almost same. Only at the place of excision, we go for division of pectoralis minor. We go for division. So we go for division of pectoralis minor. Clear? We go for division of pectoralis minor. So excision of pectoralis minor, at the place of excision we are going for division of pectoralis minor. So that is Scannellon's modification. In exam, usually examiners are asking the named mastectomies like Halsted radical mastectomy they are asking, Patey's modification they are asking, Scannellon's modification. So in Patey's we go for excision, in Scannellon's we go for division. Okay. Now see how we perform mastectomy. You can see. See, first we are giving this kind of elliptical incision. This is also known as Stewart incision. So oblique elliptical incision, that is Stewart incision. After that, we are going to raise the skin flaps. So you can see we are using this Ellis tissue forceps, raising the skin flaps with the help of cautery. After that, you can see which muscle is just behind breast, pectoralis major. So we are going to dissect off the breast tissue with the help of cautery from underlying the muscle. Clear? And after that, we are removing the whole breast tissue. So can you see here what I'm removing? Nipple, areola, skin, breast tissue, breast mass, that is simple mastectomy. Apart from this, if you are removing the lymph node, for removal of lymph node, you can see that pectoralis major and minor has been retracted. See the borders of axilla. Superiorly, axillary vein. Medially, there is serratus anterior muscle. And inferiorly, you can see latissimus dorsi. Clear? After that, you can see there is a nerve which is supplying the serratus anterior long thoracic. It is retracted. And I'm going to dissect the fat. Fat is dissected and lymph node is removed. You can see here. So fat and lymph node level 1, 2, 3 is removed. Clear? Whenever lymph nodes are also removed, you are going to close the skin flap. Before closing the skin flap, we are going to insert a Romovac suction drain. One limb is placed beneath the skin flap and one limb is there in the axilla. So this is how we perform mastectomy. It's very, very important. Clear? Now see the important questions related to complications of mastectomy. Breast is fatty tissue. You are going to perform the axillary lymph node dissection. you are going to dissect off the breast tissue. So what happens? There is collection of serous material beneath the skin flap. You are going to insert the drain. That's why this serous material is going out. But accidentally, if drain is blocked or it is accidentally removed, so there is collection of serous material in the axilla and beneath the skin flap. Can you tell me what's the name of this complication? Seroma. It is seen in 30% patients. And this question was asked in one of the latest exam, that what is the most common complication of mastectomy? Can you tell me? Seroma. This is the most common complication. This is the most common complication of mastectomy. After that, sometimes if extensive dissection has been done beneath the skin, its vascularity is gone. So you might notice wound, neck infection because of flap necrosis. So there is flap necrosis, it might lead to wound infection. After that, what are the nerves injured? First you tell me, what are the muscles in relation to breast? Serratus anterior. So can you tell me which nerve is supplying serratus anterior? Long thoracic. There is another big bulky muscle, latissimus dorsi. So can you tell me, what is the nerve supplying latissimus dorsi? Thoracodorsal. So nerves injured, long thoracic, thoracodorsal, and especially one nerve injured whenever you are performing sentinel lymph node biopsy. During sentinel lymph node biopsy, what is the most commonly injured nerve? Tell me, this is frequently asked, and that is intercostobrachial nerve. This is very important. This is intercostobrachial nerve, most commonly injured during sentinel lymph node biopsy. So it is injured during sentinel lymph node biopsy. Okay, one important question. Question is asked in this fashion, that after mastectomy, what when patient was pushing or punching the wall? Yes, what happens? There is winging of scapula. Can you see here? There is winging of scapula. So which nerve is injured? Obviously, there is injury of long thoracic nerve. So whenever there is winging of scapula, you can see here, there is winging of scapula. So there is winging of scapula. There is injury of which nerve? Long thoracic nerve. Clear? Next, some patients who are obese, you know that obesity is a risk factor for breast cancer. These patients are having too much of fat in axilla. Suppose you remove the breast, but little amount of that fat is left in the axilla. So what happens? There is persistent axillary fat pad. And one thing which you have noticed in majority of females who are undergoing mastectomy, after mastectomy, they are having edema. Why? Because there is lymphatic disruption because of axillary lymph node dissection. So axillary lymph node dissection leads to lymphatic disruption, and that's why there is lymphedema. So it is because of lymphatic disruption. It is because of lymphatic disruption. Because you are performing what? Axillary lymph node dissection. One special complication occurs. Imagine in the patient of carcinoma breast, you have done MRM, modified radical mastectomy, plus radiotherapy is also given. Usually after 10.5 years on an average, usually after 10.5 years, what happens? These patients are having worsening of lymphedema. There is violet color or purple color nodules. Worsening of lymphedema, severe pain in the affected limb. This is known as angiosarcoma. And can you tell me what is the name of this syndrome? It is one of the frequently asked questions. You can see this is how it looks like. So this is angiosarcoma, usually occurring after 10.5 years of MRM and radiotherapy. What's the name? Very, very important. It was asked many times. Stewart-Treves syndrome. What's the name? This is Stewart-Treves syndrome. Clear? So this is Stewart-Treves syndrome. So in this case, you are going to find violet or purple color nodules or brownish nodules over the skin. Patient is having worsening of lymphedema, and what severe pain is there in the affected limb. So you perform the mastectomy. Now we are going for breast conservation surgery. Second option, we can go for breast reconstruction. First, you tell me for which stage we are going for breast conservation surgery. You know, breast conservation surgery is done for early invasive breast cancer. And what is the stage? 1, 2A, 2B? It is done for early invasive breast cancer. Is done for early invasive breast cancer. So it's early invasive breast cancer. Clear? And what is the stage? In early invasive breast cancer, you know the stage is 1. So stage 1, stage 2A, 2B. It is stage 1, stage 2A, 2B. Breast conservation surgery. It is done for early invasive breast cancer. Clear? What is done here? You have to conserve the breast tissue. Only tumor with little amount of tissue around the tumor is removed. Now imagine what I'm going to do. If I'm just going for excision of lump, if I'm going for only excision of lump, can you tell me what's the name? This is lumpectomy. So you just go for excision of lump. That is known as lumpectomy. lumpectomy. Second, we can go for excision of lump. Apart from that, we are going to take at least 1 millimeter margin. Previously, it was said that for wide local excision, take 1 centimeter margin. But according to latest update, at least how much margin should be taken? 1 mm. You have to remember this is 1 mm. You have to remember this 1 mm. At least 1 mm margin is taken. At least how much? 1 millimeter, 1 mm margin is taken. What's the name? Wide local excision. And whenever you are going to excise the whole quadrant, if you excise anything in surgery, it is known as ectomy. So if you excise the whole quadrant, what is the name? Quadrantectomy. What's the name? Quadrantectomy. So excision of whole quadrant, you can see here. What's the name? This is quadrantectomy. So excision of lump, lumpectomy. Wide local excision with 1 mm margin, wide local excision. And if you remove the whole quadrant, that is quadrantectomy. What is the problem here? See, you have just removed the tumor and little amount of breast tissue around the tumor, but rest of the breast is left as such. It means these patients will be having high risk of recurrence, and to prevent risk of recurrence, what you have to give? In all patients, we have to give radiotherapy. It means in all patients of breast conservation surgery, you have to give radiotherapy. It means if there is a contraindication for radiotherapy, yes, that will be a contraindication for breast conservation surgery. So can you tell me what is the absolute contraindication for breast conservation surgery? Yes, or radiotherapy? That is pregnancy. Absolute contraindication, pregnancy. Second, suppose there are two or more than two tumors in different quadrant. It means the tumor is scattered in the breast. Two or more than two tumors in different quadrant, or patient is having what kind of diffuse malignant appearing microcalcification. Diffuse malignant appearing microcalcification. It means in this case, if you are going for breast conservation surgery, high chances are there that there will be recurrence. Next, persistently positive margins. What is the meaning? Suppose you remove the tumor and you send it for histopathology, margins are positive, means still some part of tumor is left inside the breast. Again you excise it, again it is positive. So persistently positive margins means obviously the tumor is scattered. Next, history of therapeutic radiation exposure. What is the meaning of therapeutic radiation exposure? We discussed at least 40 to 60 gray radiation exposure is already there. Patient has been given radiation 40 to 60 gray, and again you are giving this much of radiation, obviously it is going to increase the risk of other cancers in the body. Now see the relative contraindications. First, patients who are having collagen vascular disease, example like scleroderma or active lupus erythematosus. Patients who are having active lupus erythematosus. Clear? Erythematosus. Active lupus erythematosus. Clear? After that, multiple tumors are there, but in the same quadrant. Or if the patient is having indeterminate calcification, right? Means the nature of calcification is not known. Next, large tumor in small breast. So size of breast is small, but the tumor is large. It means if you are removing the tumor, nothing is left. Next, some patients are having large pendulous breast. If the patient is having large pendulous breast, it is very difficult for you to give the uniform dose of radiotherapy. And next, centrally located tumor. What is the big problem with centrally located tumor? Centrally located means the tumor is located beneath nipple and areola, right? Means if you are going to excise the tumor, you have to excise the nipple and areola. It means there is difficulty in reconstruction of nipple and areola. That's why these are relative contraindications. So how many absolute? 4 absolute, 5 relative contraindications. These are the contraindications for breast conservation surgery. And you know, if breast conservation surgery is contraindicated, can you tell me what should be done? So obviously in these cases, we go for simple mastectomy. If there is contraindication, so in these cases, we go for simple mastectomy. So simple mastectomy is done if there is contraindication to breast conservation surgery. Now see the types of breast reconstruction. First, autogenous. Autogenous means patient's own tissues are used. Alloplastic, so here we are using something of silicon gel implant, silicon implant with saline refill. And when you are using both methods, it is known as combined. First, in autogenous, can you tell me what is the most commonly used flap? Most commonly it is tram flap. What is the full form? Transverse rectus abdominis muscle flap. Next, LD flap, tell me the full form. Latissimus dorsi flap. Third, thoracoepigastric flap, lateral thigh flap, gluteal flap, and Rubens flap. Can you tell me this Rubens flap, it is based on which artery? It's based on deep circumflex iliac artery. So this Rubens flap, it is based on deep circumflex iliac artery. Okay, so deep circumflex iliac artery. This is based on deep circumflex iliac artery. That is autogenous. Alloplastic here we are using silicon implants. So you can see silicon gel implants and silicon implants with saline refill. You know that worldwide most commonly used method for breast augmentation as well as breast reconstruction, that is silicon implants. So this is most commonly used for breast augmentation. It is most commonly used for breast augmentation and breast reconstruction. It is breast augmentation and breast reconstruction. Breast augmentation and breast reconstruction. Clear? Imagine patient is having some complications related to implant. So can you tell me what is the investigation of choice? If patient is having complications related to silicon implant, you know that the investigation of choice for implant related complications, that is MRI. So MRI, investigation of choice for implant related complications. Next, combined method. Imagine some female is having large breast. You are just using flap. You can reconstruct the breast, but you cannot restore the symmetry. So that's why you are using implant also. You are using flap also. Why? To restore the symmetry. So this combined method, it is used for females who are having large breast. So combined method, what we are using, tram flap plus implant, LD flap plus implant, and this is used for the patients who are having large breast. The patients who are having large breast. So to restore the symmetry, we are using this combined method. So let's discuss the important questions related to breast reconstruction. We discussed what is the most commonly used flap, that is tram flap. What is the full form? Transversus rectus abdominis muscle flap. Is transverse rectus abdominis muscle flap. What is the best flap? That is DIEP flap. Can you tell me the full form? DIEP, that is deep inferior epigastric artery perforator flap. So why tram flap is not the best flap? Have a look. See the important points related to tram flap. First, from where we are going to take the flap? Transverse rectus abdominis muscle. And can you see it is based on which artery? Inferior epigastric vessels. You know that inferior epigastric vessels are the branch of external iliac vessels. Inferior epigastric vessels, these are branches of external iliac vessels. It is a type of free flap. So you take it and then you are going to devascularize it from donor site, and then you are going to revascularize it at recipient bed. So how you are going to revascularize it? You can see here, this is internal mammary. This is internal mammary vessels. So we are going to revascularize it with internal mammary vessels. You can see. So you can see inferior epigastric vessels, these are anastomosed to what? Internal mammary vessels. Clear? Clear? But what is the big problem after this? You can see this kind of reconstruction is done. It's a type of free flap. There is anastomosis between internal mammary and inferior epigastric. But after surgery, there is weakness. There is weakness. Why? Because you have cut the muscle and that muscle has been taken in infraumbilical region. So because of this, what's the big problem? Patient is having increased risk of hernia. There is muscle weakness. Because of that, patient will be having increased risk of hernia. That's why tram flap, it is most commonly used flap, but this is not the best flap. So what is the best flap? We discussed that tram flap, it is based on inferior epigastric vessels, and you notice that it is anastomosed to internal mammary vessels. What is the disadvantage here? We discussed that there is muscle weakness. There is muscle weakness, and because of this, what will happen? Weakness of abdominal wall. Because of that, what is the problem? Hernia. So it leads to weakness of abdominal wall because you are going to exercise the muscle. That's why there is hernia. So DIEP flap, this is the best flap. What is the full form? Deep inferior epigastric artery perforator flap. So name is self-explanatory. Deep inferior epigastric artery perforator flap. It is deep inferior epigastric artery perforator flap. Perforator flap. Clear? So the term is self-explanatory. It is based on perforators of deep inferior epigastric artery. Clear? See how it's done? So in this case, you can notice that we are just going to take skin plus fat. Muscle is spared. We are not going to take the muscle, and you can see it is based on inferior epigastric perforator. It is based on inferior epigastric perforator. And after that, since you are not taking the muscle, only skin and fat, what? It is placed at the site of surgery, means for the breast reconstruction. And here also you can see the anastomosis is done between internal mammary vessels and the perforators of deep inferior epigastric artery. So what is the good thing about this? The good thing about this, that after surgery there is no muscle weakness. You can see here, since you are not going to exercise the muscle, after surgery there is no muscle weakness. It means there is no hernia. So this is DIEP flap. This is the best flap. This is the best flap for breast reconstruction. Best flap for breast reconstruction. Clear? So DIEP flap. This is the best flap for breast reconstruction. It is based on perforators of deep inferior epigastric artery. Right? Next, latissimus dorsi flap. Latissimus dorsi. So first question, can you tell me it is based on which vessels? Obviously, it is based on thoracodorsal vessels. It is based on thoracodorsal vessels. Thoracodorsal vessels, right? How you take this flap? It's easy. You take this muscle, myocutaneous flap, and then you create tunnel, and after tunneling you are going to take it forward, and you can see here, this is the flap. I'm going to take this myocutaneous flap, we create a tunnel, and then we perform the reconstruction. So this is LD flap, also known as latissimus dorsi flap. We discussed that despite of flaps, why female patients are preferring silicone implants? Because if you're going to take a flap anywhere from the body, it is going to contain scar. After surgery, there is scar. Obviously, it's painful. So what is better? We can use the implant. Which one? Silicone implant. So nowadays, for breast augmentation also, as well as breast reconstruction also, we are using implant. So where we are using this silicone implant in case of breast augmentation, and where we are using it in case of reconstruction, you can see. For breast augmentation, can you see the muscle? This is pectoralis major. So what? You can see that the implant is placed, silicone implant, it is placed in front of muscle. It is placed in front of muscle. Clear? It is placed in front of muscle. Suppose we are going for reconstruction. You can see here, this is the muscle, pectoralis major. So here we are placing the implant. You can see the implant is being placed. Implant is placed behind the muscle. It is placed behind the pectoralis major or muscle. So this is breast reconstruction, breast augmentation. In breast augmentation, implant is placed in front of pectoralis major. In reconstruction, it is placed behind the pectoralis major. Long back in AIIMS, there was one question related to breast cancer follow-up, that how you are going to follow up a patient of breast cancer. First, history and physical examination. So initially, it should be done every 3 to 6 months for first 3 years. For the first 3 years, it should be done every 3 to 6 months. Clear? After that, every 6 to 12 months for fourth and fifth year. For fourth and fifth year, it is every 6 to 12 months and annually thereafter. Okay. Next, mammography. So mammography should be done annually, or at least beginning no earlier than 6 months of radiotherapy. It means it should be done after 6 months of radiotherapy, and usually we should do the mammography annually. The patient should do breast self-examination. It should be done annually. Pelvic examination, it should also be done annually. So breast self-examination, it is done annually. Pelvic examination, this should also be done annually. And there should be coordination of care between various health care providers, right? In exams, the questions are asked that investigations which are not recommended. Investigations which are not recommended for routine surveillance. So in blood investigations which are not recommended routinely, CBC, complete blood count, LFT, liver function test, these are not routinely recommended. In imaging, chest x-ray, ultrasound liver, CT, bone scan, MRI breast, these are not routinely recommended. So these are not recommended routinely, not recommended. Tumor markers like CA, what is CA? Carbohydrate antigen. CEA, carcinoembryonic antigen. So CA, carbohydrate antigen. CEA, carcinoembryonic antigen. Again, it is not recommended routinely. So these are the investigations which are not recommended routinely in the follow-up of breast cancer patients. Now see the prognostic factors in carcinoma breast. One important point which I want to tell you. Irrespective of malignancies, in most of the malignancies, what is the most important prognostic factor? Stage. So most important prognostic factor in most of the malignancies, that is stage. Why? Because you know that stage contains T and M. It contains T and M. All three. But there are exceptions. First, Wilms tumor, and the second is soft tissue sarcoma. What is the most important prognostic factor in Wilms tumor? Tell me. We discussed histology followed by stage. So in Wilms tumor, it is histology. It is histology followed by stage. And in soft tissue sarcoma, it is tumor grade. In the soft tissue sarcoma, it is tumor grade. Histology followed by stage in Wilms tumor. In soft tissue sarcoma, it is tumor grade. Clear? Right? So obviously for carcinoma breast also, CA breast also, most important prognostic factor, yes, it is stage. You know, adenocarcinomas, most common route of spread, it is lymphatic. Lymphatic spread is most common route of spread in adenocarcinoma. So if I have to choose one, I have to choose one between T and M. T, N, and M. I have to choose one, that single most important prognostic factor. Single most important prognostic factor, it is N, and obviously in the breast N means axillary lymph node status. So read the question carefully. Most important prognostic factor in breast cancer, stage, but the single most important prognostic factor in breast cancer, that is axillary, it is axillary lymph node status. Axillary lymph node status. Okay, next, imagine patient is having metastatic breast cancer, means already what is the stage? Stage is 4. Now this patient will respond to hormone therapy or she will not respond to hormone therapy. It is dependent on, tell me, hormone receptors. Clear? So what is the most important prognostic factor in metastatic breast cancer? In metastatic breast cancer, it is, yes, hormone receptor status. This is hormone, this is hormone receptor status. This is hormone receptor status. Hormone receptor status. So most important prognostic factor in metastatic breast cancer, that is hormone receptor status. Clear? There are some other questions which are asked in relation to prognosis. First, Nottingham prognostic index. Clear? Nottingham prognostic index. What is the formula? It is 0.2 into tumor size plus lymph node stage plus tumor grade. 0.2 into tumor size plus lymph node stage plus tumor grade. So can you see, we are including tumor size, lymph node stage, tumor grade. So this is used to select patients for adjuvant treatment. Used to select patients for adjuvant treatment. Adjuvant treatment. Okay. Nottingham prognostic index. There is another question, that's Bloom-Richardson grading, and how to remember. The mnemonic is TNM. Bloom-Richardson grading. The mnemonic is TNM. T means tubule formation, N means nuclear pleomorphism, M means mitosis. So here T, that is tubule formation. This is tubule. Okay. So this is tubule formation. N, that is nuclear pleomorphism. It's nuclear pleomorphism. Nuclear pleomorphism. Clear? And M, that's mitosis. It is nuclear pleomorphism and mitosis. So this is Bloom-Richardson grading. The components are T and M. T and M. Clear? Now, next there is another important question which was asked many times, especially in NEET PG. Van Nuys prognostic index. In short, it is also known as VNPI. Clear? So this is Van Nuys prognostic index. You know, patients of ductal carcinoma in situ, we discussed that. What are the treatment options? We can go for simple mastectomy, we can go for lumpectomy, or if the patient is having high grade tumor, in that case we can go for lumpectomy plus radiotherapy, right? So if patient is having DCIS patients who do not require radiotherapy, the patients who do not require radiotherapy, patients who do not require radiotherapy. Clear? For those patients, we are using this VNPI, Van Nuys prognostic index, and it is based on micro swag. आजकल हम सबका स्वागत कैसे करते हैं? स्वैग से. तो इसका भी स्वागत करिए आप कैसे? माइक्रो स्वैग से. सो वी आर गोइंग टू वेलकम दिस बाय माइक्रो स्वैग. माइक्रो, सी the components, very very important. Micro, that is micro calcification. That's micro calcification. Clear? S, that is size of tumor. Size of tumor. W, width of margin. Width is the width of margin. A, that's age. Age, and G, that's tumor grade. Age and G, that's tumor grade. So it's age and tumor grade. So microcalcification, size of tumor, width of margin, age, tumor grade, this is Van Nuys prognostic index. Clear? It's very, very important. There were many questions in the past, and these were actually image-based questions in relation to sentinel lymph node biopsy. First, you tell me sentinel. Sentinel means gatekeeper. So sentinel lymph node means gatekeeper lymph node means the lymph node which receives is the first lymph node which receives lymph directly from the tumor. So it's the gatekeeper lymph node, is the first lymph node receiving lymph directly from tumor. Lymph directly from tumor. Directly from tumor. From tumor. So one easy question I want to ask, that in patients of carcinoma breast, can you tell me the sentinel lymph node should be one or more than one? Let me tell you, in majority of cases in patients of CA breast, it's more than one. Who described sentinel lymph node biopsy for the first time? It was described by Cabana. In which malignancy? Cabana described sentinel lymph node biopsy for the first time in carcinoma penis. In carcinoma penis. That's why you know that sentinel lymph node biopsy in carcinoma penis, it's known as Cabana procedure. What's the name? This is known as Cabana procedure. Cabana procedure. Clear? So what are the malignancies where there is established role of sentinel lymph node biopsy? Previously only 3 malignancies were there. There is addition of 2 more. Previously there was CA breast, CA penis, malignant melanoma. And there is latest addition of head and neck and carcinoma vulva, and this was asked in AIMS. Clear? And they included what? Head and neck and carcinoma vulva. So nowadays the questions which are asked, they are asking head and neck malignancy and carcinoma vulva. So these are 5 malignancies with established role: carcinoma breast, CA penis, malignant melanoma. After that, head and neck malignancies and carcinoma vulva. Now first, what is the indication of sentinel lymph node biopsy in the patients of CA breast? If clinically there is non-palpable axillary lymph node, clinically negative axilla means clinically there is non-palpable axillary lymph node. There is it's non-palpable axillary lymph node. Clear? Axillary lymph node. Lymph nodes are not palpable, right? We are going to do the sentinel lymph node biopsy. We discussed is the gatekeeper lymph node, means the first lymph node which receive lymph directly from the tumor. What are the techniques for sentinel lymph node biopsy? We have 2 techniques. One is blue dye technique. Second is radioactive colloid technique. Blue dye. So obviously we are going to inject the blue dye. What's the name? Isosulfan blue. Blue dye, isosulfan blue. Other name is 1% lymphazurin. So this is isosulfan blue. Name of dye? Blue dye. So isosulfan blue. And for radioactive colloid technique, the name is radioactive colloid. So what is this colloid? This is technetium-99 labeled sulfur. Okay, we can go for blue dye technique or we can go for radioactive colloid technique, but majority of cases we are going to combine it together. So both of these techniques are done together. Why? Because if it is performed together, it is having maximum accuracy. So if it is combined together, it's having maximum accuracy. If it is combined together, it's having maximum accuracy. Maximum accuracy. So what should be done here? You can see here the dye is injected where? The dye is injected around the tumor. It's in peritumoral region and around the nipple, where? In the areola. Around the nipple and areola. After that, what will happen? After that, you can see that yes, there will be lymph nodes which are sentinel lymph node. The color will be blue. So you can see here the radioactive substance and dye is injected. So here there is uptake by this sentinel lymph node. It becomes blue. And with the help of gamma probe, we are going to detect the radioactivity. The lymph node which is having maximum radioactivity, it means that is the sentinel lymph node. So with the help of this gamma probe, you can see similar instrument is used. This is gamma probe. So this is the gamma probe. With the help of this gamma probe, you are going to detect the radioactivity. So with the gamma probe, we are using this gamma probe for detecting radioactivity. Lymph node which is having maximum radioactivity, that is the sentinel lymph node. So what you have to do? You have to excise the tumor, and what? You have to remove the lymph node. So we are going to excise the tumor. You can see tumor is excised. Along with tumor, we are going to excise the lymph node, and it is sent for biopsy. So this is what sentinel lymph node biopsy. So we discussed that in carcinoma breast, in majority of cases, what is the number of sentinel lymph node? Usually the number of sentinel lymph node, it's more than 1. usually the number of sentinel lymph node that is more than one. So this is sentinel lymph node biopsy. So what is the advantage of sentinel lymph node biopsy? Imagine if there is no involvement of lymph node, so axillary lymph node dissection can be prevented. If it's negative, if it's negative, what is the advantage? That we can prevent axillary lymph node dissection. So axillary lymph node dissection can be prevented. It can be prevented. Clear? So what are the image based questions which are asked? Sometimes in the image you are going to notice that the surgeon is using this gamma probe in the axilla, and question is asked, what is the name of this procedure? So you can see here the surgeon is using this gamma probe. Surgeon is using this gamma probe in the axilla for detection of radioactivity. Here you can notice what? That bluish lymph node is here. You can notice that there is bluish lymph node. Yes. So this is the sentinel lymph node. What is this procedure being performed here? Sentinel lymph node biopsy. So name of the procedure which is performed here, this is sentinel lymph node biopsy. Now what are the contraindications of sentinel lymph node biopsy? We discussed indication, clinically non-palpable axillary lymph node. So if patient is having palpable lymphadenopathy, that is contraindication. Imagine because of any previous surgery, because of some intervention, there is lymphatic disruption. So if lymphatic disruption has been done because of previous axillary surgery, patient has received chemotherapy, patient has received radiotherapy, it is contraindicated. And if patient is having multifocal breast cancer, obviously you will not get to know which lymph node is sentinel. If patient is having multifocal breast cancer, so these are the contraindications of sentinel lymph node biopsy. Coming to the complications. See, you were injecting the blue color dye. Yes, if you are going to inject the dye beneath the skin, what will happen? Tattooing. So if you are injecting the dye, obviously tattooing occurs. So this is the most common complication. After that, this dye is absorbed and this dye is excreted in urine. So dye is absorbed, it is excreted in urine. That's why there is bluish discoloration. So what happens? The urine discoloration is there. Sometimes beneath the skin, since you injected the dye, there can be necrosis. Sometimes there can be anaphylaxis. And the question which is asked most commonly, that which nerve is injured during sentinel lymph node biopsy? Tell me. The most commonly injured nerve, intercostobrachial nerve. We discussed already. This is the most commonly injured nerve during sentinel lymph node biopsy. Injured nerve during sentinel lymph node biopsy. So it is most commonly injured nerve during sentinel lymph node biopsy. So these are the complications of sentinel lymph node biopsy. I'm repeating again. The question is asked, most common complication, skin tattooing, and most commonly injured nerve, that is injury to intercostobrachial nerve. Next, in most of the exams, this is image based question. What is the name? Inflammatory breast cancer. So first question, the breast cancer which look like inflammatory condition of breast. What is that inflammatory condition of breast? Mastitis or breast abscess. So this condition looks like inflammatory condition of breast, that is mastitis or breast abscess. So what is the name? Mastitis carcinomatosa. Can you tell me the stage? We discussed T4D and it corresponds to which stage? 3B. And you know that 3B means what kind of malignancy? Locally advanced breast cancer. It means if we will be discussing the management, you are going to notice that the treatment will be similar to locally advanced breast cancer, that is multimodality treatment. And you know what is that multimodality treatment? It is neoadjuvant chemotherapy plus MRM plus radiotherapy. Got it? So it is neoadjuvant chemotherapy plus MRM plus radiotherapy, right? Now see the problem. What is the definition? Can you see here? If you notice, the breast skin is involved and more than 1/3 of breast skin is involved by inflammatory changes. What is the problem here? This is the lymphatics, okay? And within the lymphatics, what happens? The tumor cells are going to enter. So the tumor cells are going to enter within the lymphatics. So what is the big problem here? There is early lymphatic permeation. And because of this early lymphatic permeation, there is early onset of pudy orange. And because of early onset of pudy orange, early involvement of lymph node, so early lymph node metastasis, early distant metastasis. So this is one of the most malignant type of breast cancer having worse prognosis. So there is early departure of patient. So everything occurs early here. Early. So what you have to remember, definition, how much of the breast skin? More than 33% or more than 1/3 of breast skin is involved by inflammatory changes. What are those inflammatory changes? erythema. Brani induration. What is Brani induration? The kind of induration you find in abscess patient. And early onset of pudi orange. This is the question. Early onset of pudi orange. Why there is early onset of pudi orange? Because there is early lymphatic permeation of bitumor cells. So what will happen? Early lymph node metastasis. There is early lymph node metastasis. It leads to early distant metastasis. So early lymph node metastasis, it leads to early distant metastasis. So early lymph node metastasis, there is early distant metastasis. Clear? So there will be inflammatory changes in the breast skin. How much? We discussed that more than 1/3 of breast skin or more than 33% of breast skin should be involved. Presence of lump is not mandatory. Can you tell me what is the other condition where presence of lump is not mandatory? In Paget's disease of nipple. So in inflammatory breast cancer and in Paget's disease of nipple, presence of lump is not mandatory. Imagine this patient is not having the lump. So how will you make the diagnosis? Biopsy. From where will you take the biopsy? Skin. Why? Because within the skin there are lymphatics. Within the lymphatics there is presence of tumor cells. So here, this is the only condition in breast cancer where we are going for skin biopsy. So investigation of choice for diagnosis, it is skin biopsy, and we already discussed what is the stage. Stage is 3B. It corresponds to, means the malignancy is locally advanced breast cancer, and you know that here we go for multimodality treatment, that is neoadjuvant chemotherapy plus we go for MRM plus radiotherapy. And we already discussed what is the most malignant breast cancer. Inflammatory breast cancer. Which breast cancer is having worse prognosis? Inflammatory breast cancer. So this is most malignant, having worst prognosis. What are we expecting in the exam? We are expecting one image based question in which the breast will be there. There are inflammatory changes involving more than 1/3, and sometimes they ask the diagnosis, sometimes they ask the management. So this is inflammatory breast cancer. Now see other special type of breast cancer, that is breast cancer in pregnancy, right? You know, this is the most common type of non-gynecological malignancy of pregnancy. How much is the incidence? It is 1 in 3,000 live births. This is 1 in 3,000 live births. Okay, there are many similarities between breast cancer and breast cancer in pregnancy. Like, what is the most common type in both? It is invasive ductal cancer. How to make the diagnosis? Biopsy. Clear? Most common presentation, lump. So most common type is invasive ductal cancer, most common presentation is lump, and what investigation of choice for diagnosis, whether patient is pregnant or non-pregnant, it is biopsy. Now see the differences. In pregnancy you cannot go for radiation exposure. So in non-pregnant patients, the first investigation done in a suspected case of breast cancer, that is mammography, and in pregnancy it becomes ultrasound. So see the important points. Here also, what is the most common type? This is invasive ductal cancer. Invasive ductal cancer. And just like non-pregnant patients, here also, what is the most common presentation? Here also most common presentation is breast lump, right? What is the problem in pregnancy? See, in pregnancy there are pregnancy induced changes in the breast. But imagine patient is going to develop the breast cancer. Patient is confused whether these changes are because of pregnancy or because of tumor. So that's why patient is confused. That's why there is late presentation. Why? Because pregnancy-induced changes mask the signs and symptoms. Pregnancy, what is the problem? Pregnancy-induced changes mask. Pregnancy-induced changes mask the signs and symptoms. Mask signs or symptoms. Mask the signs and symptoms of malignancy. That's why these patients are coming late. There is late presentation. And if there is late presentation, in what percentage of patient there is already axillary lymph node metastasis? In pregnant patients, at the time of presentation, approximately 75% patients are having axillary lymph node metastasis. We discussed that we should not go for mammography because there is radiation exposure. So here, the first investigation done in a suspected case of breast cancer in pregnancy, it's ultrasound. But investigation of choice for diagnosis, it is same, biopsy. Now see, treatment protocol is very similar. We discussed that pregnancy is an absolute contraindication of breast conservation surgery. So if patient is having early invasive breast cancer, like stage 1, 2A, 2B. Stage 1, 2A, 2B. So obviously we are not going for breast conservation surgery. So here we are going for simple mastectomy. So in this case we are going for simple mastectomy. Simple mastectomy. One thing is clear. Second, imagine patient is having locally advanced breast cancer 3A, 3B, 3C. The protocol is same, neoadjuvant chemotherapy plus MRM plus radiotherapy. But what is the problem? You know that during first trimester organogenesis is occurring, and if organogenesis is occurring during first trimester, obviously we cannot give chemotherapy. So if you cannot give chemotherapy during first trimester, you can give it after completion of first trimester. So it's neoadjuvant chemotherapy after completion of first trimester. After completion of first trimester. Why? Because organogenesis mainly occurs during first trimester. Next, there is maximum risk of abortions during first trimester, right? You know that general anesthesia increases the risk of abortion. So we should not give general anesthesia during first trimester, but we can give it during second trimester. So MRM should be done during second trimester. It should be done during second trimester because GA can induce abortion, general anesthesia, in first trimester. You cannot give radiotherapy during pregnancy. So that's why radiotherapy, it can be given after delivery. It can be given after delivery. Clear? So it is neoadjuvant chemotherapy plus MRM plus radiotherapy. Neoadjuvant chemotherapy after completion of first trimester, MRM during second trimester, radiotherapy after delivery. So let me tell you, let me summarize very easy. Yes, the most common type is same. Invasive ductal cancer in pregnant as well as non-pregnant patient. Type, invasive ductal cancer, presentation same, lump, investigation of choice same, biopsy, treatment protocol is very similar. For early invasive breast cancer, we go for simple mastectomy, and LABC, the treatment is same. Neoadjuvant chemotherapy plus MRM plus radiotherapy, only you have to go for proper spacing. Now see the special type, male breast cancer. This is responsible only for 1% of breast cancer. What is the most common type? In males and females, the most common type is same. It is invasive ductal cancer. It is invasive ductal cancer. We discussed that. In females, there is duct as well as lobule. So lobular carcinoma, it is exclusively seen in females, but ducts are present in both males and females. That's why in both males and females, the most common type is invasive ductal cancer. Other similarity, ERPR, it is positive. In what percentage? In 80% patients. So hormone receptor positive, it is positive in 80% patients. HER2 new, it is positive in 35% patients in both males and females. In both males and females. Clear? ERPR is positive in 80%, HER2 new is positive in 35% cases. Carcinoma breast in males seen in 6th decade. So see the similarities. First, most common type is same. Invasive ductal cancer, HER2 new and ERPR positivity is same. Second, the risk factor is very similar. So what? States of hyperestrogenemia. It means estrogen doesn't matter whether this is endogenous or exogenous. It is endogenous or exogenous. We discussed that in females, states of hyperestrogenemia is a risk factor. So in males also, endogenous or exogenous estrogen is going to increase the risk of breast cancer. So see the similarities. Most common presentation in males and females, it is lump. So most common presentation is both, same in both. Most common type, invasive ductal cancer. Invasive ductal cancer. Clear? It is same in both males and females. Hormone receptor status, yes, it is positive in 80% patients in both. Risk factors, it is almost similar. States of hyperestrogenemia. This is the state of hyperestrogenemia. So it doesn't matter whether it is endogenous estrogen or exogenous estrogen. So what are the states of hyperestrogenemia? See the physiology first. You know that catabolism of estrogen occurs in the liver. Catabolism of estrogen occurs in the liver. If patient is already having diseased liver, that patient will be having states of hyperestrogenemia. So you know that there are states of hyperestrogenemia in patients who are having chronic liver disease or cirrhosis. So increased estrogen levels. Patients who are having chronic liver disease or cirrhosis, patients suffering from infertility, or there is bilateral undescended testis. Another risk factor, androgen insensitivity syndrome. Can you tell me what's the other name? Other name, it is testicular feminization syndrome. androgen insensitivity syndrome, also known as testicular feminization syndrome, Klinefelter syndrome, and which mutation? BRCA2. We discussed that both BRCA1 as well as BRCA2 are responsible for breast cancer in both males and females. BRCA1 mainly in females, BRCA2 mainly in males. How to remember? Ladies first. Another important point where you are doing the mistake in exam, are very prone to do the mistake. See, gynecomastia, it precedes breast cancer in 20% patients. Means before breast cancer, patient will be having enlargement of breast. There is gynecomastia. But see, gynecomastia itself is not a risk factor for breast cancer. Two separate statements. Gynecomastia itself, it's not a risk factor. It's not a risk factor for breast cancer, but it precedes breast cancer in 20% patients. Now see the clinical features we already discussed. What is the most common presentation? Lump. It is the lump. This is lump. Okay. Now see the problem. What is the difference between male and female breast? This is a female patient. Suppose this female patient is having a lump. This is a male patient. This is a breast of male patient, and there is a lump. Okay. What is the problem? Females are having too much of breast tissue, so it will take time. It will take time for this tumor to involve the nipple. But what happens in males? There is scanty breast tissue, and since there is scanty breast tissue, there is early involvement of nipple. The size of nipple is also small in the males. That's why when nipple is involved, actually you are going to find that there is ulceration. So there is early involvement of nipple. Why? Because you know that in males there is scanty breast tissue. So what happens? There is ulceration of nipple. Ulceration of nipple. And what is the big problem with the males? No male on this earth can ever imagine that he will develop breast cancer. So when these males are going to develop breast cancer, they just notice that ulceration and they think that it is just a wound, and that's why there is late presentation. Here also investigation of choice for diagnosis, it is biopsy, and stage by stage treatment and prognosis, it is similar to female breast cancer. So stage by stage treatment and prognosis. Stage by stage treatment and prognosis, it is similar to female breast cancer. It is similar to females breast cancer. Clear? This is male breast cancer. Now see this image and tell me the diagnosis. You can see that there is chronic eczematous eruption around the nipple, and nipple is almost destroyed. So there is eczematous eruption of nipple. Nipple is almost destroyed. So this is Paget's disease of nipple. What is the big problem with Paget's disease? Actually, it is having underlying malignancy. Sometimes ductal carcinoma in situ, sometimes invasive ductal cancer. So it is associated with DCIS, or sometimes there is invasive ductal cancer. Invasive ductal cancer. Okay. Now see the problem. There is one variant of malignant melanoma which is going to spread on the surface. If it is going to spread on the surface, superficial spreading. So how to differentiate this superficial spreading malignant melanoma from Paget's disease of nipple? Can you tell me the marker for superficial spreading malignant melanoma? Frequently asked marker, S100. So the marker is S100 for superficial spreading malignant melanoma. And what is the marker for Paget's disease of nipple? This is CEA. Marker for Paget's disease of nipple, that is carcinoembryonic antigen. We discussed in inflammatory breast cancer what? That presence of lump, it's not mandatory. So presence of lump, it's not mandatory for the diagnosis of Paget's disease of nipple as well as inflammatory breast cancer. So here, presence of lump, it's not mandatory. It's not mandatory. So when these females are coming to you, what is the presentation? They will tell you that, sir, this lesion is there. And what's that lesion? Chronic eczematous eruption of nipple. Sometimes nipple is also destroyed. Now, how to make the diagnosis? Here, the diagnosis is made by combination of complete mammography plus biopsy, because we discussed that there is hidden malignancy, DCIS, or sometimes invasive ductal cancer. So, mammography is done to rule out occult multicentric disease. Why complete mammography? To rule out occult multicentric disease, occult multicentric disease. So why we do the biopsy? For confirmation, because you can notice that there is presence of Paget cells. So presence of Paget cells, what is the special feature? You can see that the cells are having large nucleus and pale cytoplasm. These are Paget cells which are having large nucleus, and you can notice that there is pale cytoplasm. There is pale cytoplasm. Clear? This is the only condition in this chapter where two investigations are required simultaneously just to confirm the diagnosis. So biopsy Y to mark the presence of Paget cells. Paget cells. So I'm repeating. How to make the diagnosis? Investigation of choice for diagnosis is a combination of complete mammography and biopsy. So it's the complete mammography and biopsy. On complete mammography, there is occult multicentric disease we have to rule out, and biopsy Y to make the diagnosis because there will be Paget cells. These are having large nucleus and pale cytoplasm. So how to treat it? Treatment, it is simple mastectomy. So patients who are having Paget's disease of nipple, since there is underlying malignancy, we go for simple mastectomy. Next tumor is cystosarcoma phyllodes. It's very easy to understand, just break it. First, there is cyst. Most of the sarcomas are solid, but it will be having cystic areas also. For first important point, there will be cystic areas. Cystic areas will be there. And what is the cause of cystic areas in cystosarcoma phyllodes? It is because of hemorrhage and necrosis. One thing is clear. Second, it is a type of sarcoma. You know, what is the most common route of spread in carcinomas? Usually there is lymphatic spread. There can be hematogenous spread also. But in adenocarcinoma, usually most common route of spread is lymphatic. In sarcomas, there is no lymphatic spread. Exclusively hematogenous spread is there. So since it is sarcoma, obviously there is hematogenous spread. You know that in sarcomas, what is the investigation of choice? Biopsy. And because of this hematogenous spread, what is the most common site of metastasis? It is lungs. Most common site of metastasis, lungs. Third name is phyllodes. Phyllodes means there will be leaf-like appearance. Phyllodes. So there is leaf-like appearance, right? So there is leaf-like appearance. So cystic areas, sarcoma, it's a type of sarcoma having hematogenous spread. Most common site of metastasis, lungs. Investigation of choice, it is biopsy. Phyllodes means leaf-like appearance. Other name, it is serocystic disease of Brody. Another feature of sarcoma, you know that carcinomas are having epithelial origin. Sarcomas are having mesenchymal or stromal origin. Right. So this is sarcoma. So there is biphasic proliferation. Biphasic proliferation of what? Mammary epithelium as well as connective tissue. So its exception here, there is biphasic proliferation of, or dual origin is there. Biphasic proliferation of mammary epithelium as well as connective tissue. Clear? Connective tissue. Right. Now see the important questions related to pathology. First, what kind of stroma is there? There is monoclonal stroma, and these tumors are having rapid growth. Because there is rapid growth, what will happen? The overlying skin is stretched. That's why, because of this rapid growth, you are going to notice that there is pressure atrophy or necrosis of skin. Important point. Skin is not directly involved or invaded by tumor, but because of rapid growth of tumor, it is stretched. So there is pressure atrophy or necrosis. What is the cause of cystic areas? We discussed that. Cystic areas will be there in the tumor because of hemorrhage and necrosis. So it is because of hemorrhage and necrosis. Sometimes this question is asked in integrated fashion, and question will be described and then they give this histopathological image. So you can see here, there is leaf-like pattern. Can you see here? Leaf-like pattern, and this is known as what? Phyllodes. So this leaf-like pattern, this is known as phyllodes. Clear? Now see how the tumor looks like. Just by looking at the tumor, you can make the diagnosis. You can notice here that the affected breast is massively enlarged. And can you see the skin? Skin is stretched. There is pressure atrophy or pressure necrosis. So important points, affected breast, it is massively enlarged. And if you do the palpation, there is bosselated appearance. What is bosselated appearance? It is uneven appearance. Suppose you have a bunch of grapes and you are trying to palpate that bunch of grapes, that kind of appearance, bosselated appearance. We notice that there is pressure atrophy of skin. Important point. Most common route of spread, it is sarcoma. So we discussed hematogenous. This is hematogenous. Clear? Lymphatic spread, it is not seen. Lymphatic spread, this is not seen. And if there is no lymphatic spread, obviously there is no lymph node metastasis. if there is no lymph node metastasis, obviously we are not supposed to go for axillary lymph node dissection. So even if patient is having malignant tumor, what is the maximum treatment done here? Simple mastectomy. So just simple mastectomy should be sufficient. No need to do MRM, because MRM is simple mastectomy plus removal of level 1 and level 2 lymph node. So what is sufficient? Simple mastectomy, because there is no lymph node involvement. Another feature which is very, very important, the structures which are not involved: nipple, breast skin and chest wall. If nipple is not involved, so obviously there is no retraction, deviation, ulceration, no retraction, deviation, ulceration. Breast skin, it is not involved, that's why no skin fixity, there is no skin fixity. Chest wall, again it's not involved, so it's mobile over chest wall. Tumor is mobile over chest wall, tumor is mobile. Clear? So it is mobile over chest wall. Chest wall, three characteristic features. These structures are not spared: nipple, breast skin and chest wall. Right? How to make the diagnosis? It is a sarcoma. So how to make the diagnosis of sarcomas? Biopsy, and we discussed most common site of metastasis, lungs. Treatment: sarcomas, if suppose the tumor is benign, we go for wide local excision. For benign tumors, guys, wide local excision, right? But if tumor is malignant, what? Simple mastectomy is sufficient. Since there is no lymph node involvement, this is a common mistake you do in exam. Examiner is going to ask you malignant cystosarcoma phyllodes, what's the treatment of choice? First option simple mastectomy, then modified radical mastectomy, then radical mastectomy. Go for simple mastectomy. No need to remove lymph node. Why? There is no lymph node involvement. But see, there are certain sarcomas which are having lymphatic spread. That's why if there is lymphatic spread, there is lymph node involvement. And if there is lymph node involvement, we go for lymph node dissection. We go for lymph node dissection. How to remember? Mnemonic is Marcis. Mnemonic is Marcis. So what? M, that is malignant fibrous histiocytoma. A, that is angiosarcoma. This is angiosarcoma, right? R, tell me R, rhabdomyosarcoma. R, that is rhabdomyosarcoma. C, that is clear cell sarcoma. It is clear cell. So that is clear cell sarcoma. E, epithelioid sarcoma. So E, that is epithelioid. This is epithelioid sarcoma. And S, that is synovial sarcoma. This is synovial sarcoma. So this is very, very important. Marcis, right? These are the sarcomas which are having lymphatic spread. That's why there is lymph node involvement, and that's why in these 6 sarcomas we go for lymph node dissection. Now see the recent advances in breast cancer. There are certain topics which are very, very hot, and these topics are frequently asked nowadays in exams. First, molecular classification of breast cancer. This question was asked in one of the latest exam. It is based on gene expression profiling. Molecular classification of breast cancer, this was a question. It is based on gene expression profiling. There is a luminal criteria. Now see the types: Lum A or luminal A. What are the receptors which are positive? So Lum A, here, estrogen receptor, this is positive. Progesterone receptor, this is positive, but HER2 new, this is negative. Estrogen receptor positive, progesterone receptor positive, HER2 new negative. Can you tell me how many are positive? 2. So this is known as double positive. This is double positive. Here, there is low expression of cell proliferation marker, that is Ki67. This is one additional feature you have to remember. Low expression of, there is low expression of cell proliferation marker. And what's that? Ki67. Low expression of cell proliferation marker, that is Ki67, right? Now Lum B. Lum B is actually triple positive. It means here ER is positive. Here progesterone receptor, this is also positive. Here HER2 new, it's also positive. So this is known as triple positive. What's the name? How to remember? This is triple positive. This is triple positive. Very, very important. Clear? This one is having high expression of Ki67. Additional feature you have to remember here. There is high expression or increased expression of Ki67. Ki67. Right? After that, normal breast-like. This normal breast-like, it is ER positive and it is well differentiated. ER positive and this is well differentiated, well differentiated. After that, basal cell type. What is the other name of basal cell type? It is triple negative. Triple negative means this is ER negative, this is PR negative, clear? This is HER2 new negative. So this is ER negative, PR negative, HER2 new negative, but it is positive for EGFR, myoepithelial markers, cytokeratin. So it is positive for EGFR means epithelial growth factor receptor, myoepithelial markers, and cytokeratin. You have to remember which cytokeratin, 5, 6, 17. So CK5, 6, 17. Cytokeratin 5, 6, 17. This is another question. Important point that basal cell type, this is triple negative. This is triple negative. Okay. Next is HER2 new type, means obviously it is ER negative, PR negative, HER2 new positive. HER2 new type. So this is ER negative, estrogen receptor negative, progesterone receptor negative, but this is HER2 new positive. Clear? This is HER2 new positive. Okay. Right. Now see, classification starts from AB. A, B, C, D, E, any classification which starts from A, B, C, D, E or 1, 2, 3, 4, 5. If it starts from A, B, C, D, E, what is the most common type? A. 1, 2, 3, 4, 5. What is the most common type? 1. So what is the most common type having best prognosis? It's Lume A. Lume A, this is most common. It is having best prognosis. Best prognosis. Which one is having worst prognosis? Triple negative. Means the basal cell type, it is having worst. This is having worse prognosis. So triple negative having worse prognosis. Clear? So this is luminal criteria. It's very important. You have to remember this is molecular classification of breast cancer based on gene expression profiling. Best prognosis Lume A, worst prognosis triple negative. So best prognosis double positive, worst prognosis triple negative. Multi-gene test, these are also asked in exam nowadays. Imagine you have a newly diagnosed patient of breast cancer, a female newly diagnosed case of breast cancer. Suppose biopsy is done. On the basis of biopsy specimen, we have to assess the expression of multi-genes. Clear? And on the basis of expression of multiple genes, we predict whether the tumor will respond to chemotherapy or not, whether patient is having recurrence rate or not, what's the likelihood of survival, and how much is the likelihood of recurrence rate. So on the basis of expression of multiple genes, you are going to see the expression on biopsy specimen. So on the basis of expression of multiple genes, we are going to predict responsiveness of chemotherapy, likelihood of survival, and likelihood of recurrence rate in a newly diagnosed female who is having breast cancer. What is the patient profile? This patient profile was asked. In what kind of patient profile? If her ER/PR is positive, this was asked in AIMS. ER/PR is positive, lymph node is negative, HER2 new is negative. The patient profile, ER/PR is positive, lymph node is negative, HER2 new is negative. So I'm repeating it again. A newly diagnosed case of breast cancer. She came to you. Her estrogen receptor, progesterone receptor is positive, lymph node status negative, HER2 new is negative. On the basis of biopsy, we are going to see the expression of multiple genes to predict responsiveness of chemotherapy, likelihood of survival, and likelihood of recurrence rate. So name is multi-gene test. So multiple genes are assessed. How many genes can you tell me in Oncotype DX? 21 genes. Oncotype DX 21. PAM 50. How many genes? 50 genes. PAM 50, 50. Mamma print, how many genes? 70 genes. So Mamma print, how many genes? 70 genes. Clear? This Oncotype DX, these genes are assessed and this is used for BPC, not only for breast. Apart from breast, it is used for prostate as well as colon. Clear? So how to remember? Oncotype DX going to assess 21 genes and it is used for breast BPC. Breast, P means prostate. So it is breast, prostate, and C means colon. So it is breast, prostate, and colon. Clear? So these patients, in these patients, we have to assess the responsiveness to chemotherapy. Patient profile, ER/PR positive, lymph node negative, HER2 new negative. So this is multi-gene test and see the number of genes. Oncotype DX 21, PAM 50-50, MammaPrint 70. BRCA1, BRCA2, when Indian examiners got to know about Angelina Jolie, that her aunt was having breast cancer and Angelina Jolie is having BRCA1 mutation. What? Lots and lots of questions are being asked about BRCA1 and BRCA2. First, tell me, what is the chromosome number for BRCA1? 17, BRCA2 13. What are the similarities in BRCA1 and BRCA2? In both, early age of onset. So patient might be in third decade, fourth decade having breast cancer. Usually breast cancer is seen in fifth or sixth decade. It is bilateral, and what is the most common type? Invasive ductal cancer. Now see, hormone receptor, it is negative. In BRCA1 negative, in BRCA2 it is positive. In BRCA1 the tumor is poorly differentiated. Here it is poorly differentiated. In BRCA2 it is well differentiated. It is well differentiated. So relatively, if you compare the prognosis, obviously BRCA2, it is having better prognosis if patient is having breast cancer. So for BRCA2, relatively better prognosis. Why? Hormone receptor is positive, it's well differentiated. Other differences. Apart from breast cancer, there is increased risk of OCP. Which malignancy? O means ovary, C means colon, P means prostate. Ovary, colon, prostate. Okay. In BRCA2, same OCP, that is ovary, colon, prostate. So this is ovary, colon, prostate. Okay. Ovary, colon, prostate. Apart from ovary, colon, prostate, pancreas, OCP plus GSM. So it is pancreas, G means gallbladder, S means stomach, M means melanoma. So G, that is gallbladder, S means stomach. It is gallbladder, stomach and melanoma. Gallbladder, stomach and melanoma. Okay. Next, how much is the lifetime risk of development of CA breast and CA ovary if patient is having BRCA1 mutation? So carcinoma breast, lifetime risk, it is 60 to 80%. And lifetime risk of carcinoma ovary, how much? It is 30 to 40%. How to remember? Risk of CA ovary is just half of risk of breast cancer. Got it? So CA breast, lifetime risk is 60 to 80% in BRCA1, carcinoma ovary 30 to 40%. Clear? So there is increased risk of breast cancer mainly in females. In BRCA1, mainly in females. In BRCA2, mainly in males, means it can lead to breast cancer in both males and females. 1, mainly in females, 2, mainly in males. How to remember? Ladies first. Now see the risk of cancer associated with benign breast disease and carcinoma in situ. Imagine what kind of abnormality patient is having. Non-proliferative lesions, patient is having sclerosing adenosis or duct papilloma. If these problems are there, how much is the relative risk? There is no increased risk. In these cases, there is no increased risk of breast cancer. If patient is having florid hyperplasia, for florid hyperplasia, the risk is 1.5 to 2-fold. It is 1.5 to 2-fold increased risk. But if patient is having atypical ductal hyperplasia, atypical lobular hyperplasia, in these cases, the increased risk is 4-fold. But if there is, this question was asked, if there is ductal involvement by the cells of atypical ductal hyperplasia, if there is ductal involvement, then the risk is 7-folds. And maximum risk whenever there is LCIS, DCIS, lobular carcinoma in situ, ductal carcinoma in situ, here, how much is the risk? 10-fold. 10-fold. So this table is important. You have to remember. Sometimes they ask the question like this, that which of the following abnormality doesn't have the risk of breast cancer? They give the option non-proliferative lesion, sclerosing adenosis or duct papilloma. So this is important. Next is aberrations in normal development and involution. In short, it is known as ANDI. Aberrations in normal development and involution. First, you tell me, what is the first sign of puberty in females? Thelage. So from thelage till involution of breast, whatever the changes are occurring, those are included in ANDI. Can you tell me, if the age of female is 15 to 25 years, what is the abnormality? Most common abnormality in this age? Fibroadenoma. What is the abnormality? She is having fibroadenoma. Clear? If the age of female is 25 to 40, what is the problem? You must be knowing fibroadenosis. It is fibroadenosis. Clear? And whenever age is more than 40, what? It is fibroadenosis, but these females are also going to develop fibroadenosis. What else? Ductictasia. So fibroadenosis, these are also going to develop ductictasia. So age-wise, 15 to 25, most common abnormality, fibroadenoma. 25 to 40, more than 40 in both. Most common is fibroadenosis, which is also known as fibrocystic disease. But if age is more than 40, there might be ductictasia also. One by one, we are going to discuss. First of all, see the fibroadenoma. It's a benign tumor. What is the other name of fibroadenoma? Also known as breast mouse. It is also known as breast mouse. Can you tell me why? Because this tumor is highly mobile. That's why it's known as breast mouse. We discussed already age group 15 to 25 years. So these are college going or school going females who are coming to you and saying that, sir, I'm having lump, and if you perform the examination, it is firm, it's mobile. So most common presentation, it's a lump. What kind of lump? It's firm. It's firm. It's highly mobile. Since it is highly mobile, that's why the name is breast mouse. How to perform the diagnosis? Here, FNAC is sufficient. So, investigation of choice for diagnosis, FNAC. FNAC. Suppose you are going for mammography. Usually, we don't go for mammography if the age of female is less than 35. Why? Because breast is dense, it's glandular. But suppose you go for mammography, you can see in this image. What? Here you can see in this image. There is nipple, which is normal. You can see the opacity, having smooth opacity, and you can see what? Corn calcification, right? So in majority of cases, you know that, yes, it's a benign tumor. So what we advise, we just advise observation. But what happens? Sometimes we have to go for surgical excision. Suppose it's a suspicious lesion or patient insists for excision for cosmetic lesions. So surgical excision is done for suspicious lesions, or for cosmetic lesions. Suspicious lesions and for cosmetic lesions, clear, we go for surgical excision. Now we are going to discuss mastalgia. What are the types of mastalgia? It is non-cyclical or cyclical? Non-cyclical, cyclical. Cyclical means pain follows the cyclical pattern of menses. So what happens? These patients are having severe pain during menstruation. Clear? So one by one we are going to discuss. First of all, we are going to discuss this non-cyclical mastalgia. Non-cyclical. In non-cyclical, first is Tietz syndrome. What is the other name of Tietz syndrome? It is costochondritis. Costochondritis means inflammation of one or more costal cartilage. So here there is inflammation of one or more costal cartilage, costochondritis. Clear? So if there is costochondritis, obviously what you have to inject? Inject the steroid. So intralesional injection of steroids. Treatment, we go for intralesional injection of steroids. Intralesional injection of steroids. That is Tietz syndrome. Next is image-based question. You can see here. You can notice that this patient is having what? String phlebitis, superficial thrombophlebitis of inframammary veins. There is superficial thrombophlebitis. If you feel it, it feels like a cord or like a string. So this Mondus disease, it is also known as string phlebitis. It feels like a cord or feels like a string. The question which is asked in exam, they ask, what is the involved vein? So most commonly involved vein, it is lateral thoracic. It is lateral thoracic and thoracoepigastric. So it is lateral thoracic, clear, and thoracoepigastric. Thoracoepigastric. So lateral thoracic and thoracoepigastric, right? There is inflammation, so obviously we go for NSAIDs. And imagine there is no response. In case we have to go for excision. So if there is no response, in that case, we go for excision. Excision. Clear? So this is image-based question. Superficial thrombophlebitis of inframammary veins. What's the name? Mondus disease, also known as string phlebitis. Now see the cyclical mastalgia. Mainly these patients are having fibroadenosis or fibrocystic disease. If you're going to talk to married females in your family or in your relatives whose age is 25 to 40, having one or two kids, what kind of symptom they are telling you? That, sir, I'm having maximum pain before menses or during menstruation. Age 25 to 40, she will tell you that if I press the breast, what happens? Serous discharge is coming from bilateral multiple ducts. And patient is having heaviness in the breast, lumpy breast. So what is this actually? This is fibroadenosis or fibrocystic disease. So there is maximum pain before menses, age usually 25 to 40 years. She tells you about serous discharge from multiple ducts bilaterally. So there is serous nipple discharge from multiple ducts and it's bilateral. Patient is having heaviness in the breast, lumpy breast. So how to make the diagnosis? Usually we send the patient for ultrasound. So diagnosis is made by ultrasound. What happens? If you perform the examination, suppose patient is complaining of lumpy breast, but if you perform the examination, there is no well-defined lump. On examination, there is no well-defined lump. So there is no well-defined lump. Clear? Diagnosed by ultrasound. Treatment. These patients are actually obese also. So we ask the weight reduction. We ask them to reduce the weight, regular exercise. An important point, decrease the caffeine intake. Regular exercise, decrease the caffeine intake. Decreased caffeine intake. Caffeine intake. Right? You have seen that we are going to advise vitamin E capsule or primrose oil capsules. In one of the latest exam, this question was asked that this primrose oil capsule, it should be given for maximum duration of 3 months. So maximum duration, this primrose oil capsule should be given. Maximum duration, it's 3 months. You have to remember, this question was asked. Primrose oil capsules are given for maximum duration of 3 months. And even if patient is still not improving, there is no improvement, in these patients, we have to start low dose tamoxifen. So low dose tamoxifen should be started if still there is no improvement. The patients who are having fibroadenosis, which is also known as fibrocystic disease. Now see, during last decade of reproductive life, it's usually 5th decade. During 5th decade, what is the problem? There is non-integrated involution of epithelium and stroma. Non-integrated involution of epithelium and stroma. Epithelium and stroma. What's the big problem? These patients are having breast cyst. And problem, these patients are having multiple cysts. Suppose the patient is, this is the patient and this kind of cyst is there. So in the breast, you are going to see multiple cysts. It is because of non-integrated involution of epithelium and stroma in which decade? 5th decade. Patients are having multiple cysts. Sometimes there is sudden presentation. And if there is sudden presentation, what? Patient think that it is malignancy. If there is sudden presentation, it can mimic malignancy. It can mimic malignancy. Malignancy. Okay. How to differentiate it? Actually, it is bilateral, and in both breasts there are multiple cysts. Right? How to make the diagnosis? Obviously, we have to insert a needle and perform the aspiration and perform the ultrasound. So it is ultrasound and aspiration. For diagnosis, we use ultrasound, we aspirate. So from the cyst, aspiration is in. Treatment is aspiration. Suppose still there is recurrence, then re-aspiration. We perform aspiration. If there is recurrence, re-aspiration. Suppose after re-aspiration there is residual lump. If lump is there, residual lump, in these cases you should go for either core biopsy or go for excision. So even after re-aspiration there is residual lump, go for core biopsy or excision. So what kind of question will be given in exam? A 5th decade, female in the 5th decade, multiple lesions in the bilateral breast on ultrasound. Sometimes there is sudden presentation, this is breast cyst. What you do next? Go for ultrasound and after that you perform aspiration. Recurrence, re-aspiration. If there is a residual lump, in that case go for core biopsy or excision. Now see, this question almost in each and every exam, almost every year this question is asked, and usually it's image based. Breast abscess. Can you tell me, breast abscess is more common in which females? Lactating females, especially primaries. It is seen in lactating females, primaries. Why? Because of faulty breastfeeding technique. There is trauma around the nipple. So what you will find? Cracked nipple because of bite by the infant. There is faulty breastfeeding technique. There is cracked nipple or trauma around the nipple. There is one organism from the skin which goes inside. So what's the most common organism? It is Staph aureus. So most common organism is Staph aureus. It is Staph aureus. Clear? When patient is having breast abscess, obviously here there is collection of pus inside the breast. You are going to see the inflammatory changes. So you are going to notice redness in the breast skin. Patient will be having pain, tenderness. Patient will complain of fever and chills. This patient will tell you that she is not able to feed the baby from the breast. Why? Because there is severe pain. So affected breast is having the milk. Milk is there. Breast is engorged. So there is pain and tenderness, fever with chills and rigor. chills and rigor, engorged breast, and erythema. These are the findings. And most important, the female is lactating female. So whenever there is pus collection, first you have to confirm how. Yes, you insert a needle, aspirate. If frank pus is there, obviously we go for incision and drainage, and after that we give antibiotics. So needle is being inserted, after that aspiration is done. You can see the frank pus is being aspirated. It means this is the site of abscess. After that you have to give the incision and drainage. So give the incision. We drain it. Clear? When the pus is drained, you have to perform the irrigation of this cavity with the help of betadine and hydrogen peroxide. You perform the irrigation. And after irrigating this cavity, we have to insert a drain also. So after doing this incision and drainage, we have to put a drain. So you can see irrigation is being done. After that, we are supposed to put the drain. Clear? And after putting the drain, we are going to close it, or sometimes we just leave it open. Clear? So this is the management, incision and drainage plus antibiotics. Question, can you tell me what is the first line agent given for Staph aureus? We give cloxacillin. This was asked in NEET PG. We give cloxacillin or we give dicloxacillin. So cloxacillin or dicloxacillin, it is given for 10 to 14 days. Clear? So it is cloxacillin or dicloxacillin, it is given for 10 to 14 days. So this is breast abscess. Nowadays you have noticed, especially in Indian females, the tendency of smoking is increasing, right? So these females are very prone to develop smoking related conditions, like we discussed that there is increased risk of breast cancer, increased risk of duct ectasia, Zuska's disease, Monders disease. What is Zuska's disease? Recurrent periductal mastitis. So patient is having recurrent breast abscess, more common in smokers. And how to manage these patients? Obviously we go for IND plus antibiotics. So IND plus antibiotics, what's the name? This is Zuska's disease. Clear? So this is about the breast. Let's discuss the MCQs. Very, very easy questions. Can you tell me? Biopsy and immunohistochemistry of breast lump reveal luminal A. Luminal A type changes. Which of the following are components of luminal A? First, ERP positive, PR positive, HER2 positive. This is triple positive. This is Lum B. This is triple positive. This is Lum B. You can see ER positive, PR positive, HER2 negative with low proliferation of Ki67. Clear? This is Lum A. So this is Lum A. There is no high proliferation, triple negative. It is also known as basal cell type or basal cell type. That is triple negative. So what is the correct answer for this question? It is B. Lum A, it is ER positive, PR positive, HER2 negative with low proliferation of Ki67. This is double positive. It is most common type having best prognosis. Now see this question. 30 years old female presents with complaint of palpable painless mass in the left breast. Can you see the age? 30, right? On examination, mass was highly mobile. Can you see breast mass? Highly mobile, size 3 into 3 centimeter. It was rubbery in consistency. Fibroadenoma is firm and rubbery. What is the most likely diagnosis? It's fibroadenoma. Clear? Because that's highly mobile. Phyllodes tumor. Here, the affected breast is massively enlarged, usually 5th to 6th decade. Breast abscess, patient will be having fever. Here, there is massive enlargement of breast, massive enlargement. Invasive ductal carcinoma, it is seen in 5th to 6th decade, and usually mass is not mobile. It's not mobile. It is hard in consistency. So it is not firm and rubbery, it is hard. So what is the correct answer here? Fibroadenoma. Next question. A female patient presents to OPD 10 days postpartum. See, lactating females, 10 days postpartum. She is having history of fluctuant breast mass, tenderness, high-grade fever, cracked nipple. So you can see history of cracked nipple, fever, mass, tenderness. It means she is having abscess. Most probable diagnosis, obviously breast abscess. This is breast abscess. It's not only engorgement, no acute mastitis because there is mass, means that is the abscess cavity, no fibroadenoma. So correct answer is B, that's breast abscess. Now see this question. 60 years old female presents with redness of skin of right breast. Okay. On palpation, no lump was there. There is no history of fever. On skin biopsy, malignancy was detected. We discussed that. There is only one malignancy in which biopsy, skin biopsy is diagnostic. What? Inflammatory breast cancer. Why? Because you know that these are the lymphatics. Within the lymphatics, there is presence of tumor cells. And can you see what is the definition? When more than one third of breast skin is involved by inflammatory changes, can you see the redness? Involving more than one third of breast skin, no mass is there, still there is malignancy. So this is inflammatory breast cancer. Can you tell me what is the stage? Yes, it is T4D. It corresponds to which stage? 3B. 3B. So this is locally advanced breast cancer, T4D, 3B. What is the correct answer? Correct answer is stage 3B. So it is stage 3B. Similar question was asked in INICT. Genetic testing for BRCA1, BRCA2 indicated for all of the following except. If patient is having BRCA1 or BRCA2, there is early onset of breast cancer. It is bilateral breast cancer. There is invasive ductal cancer. So early onset breast cancer diagnosed in postmenopausal female more than 50. No, it's a usual breast cancer. Male breast cancer, it's unusual. Yes. Bilateral breast cancer, yes. Breast and ovarian cancer, yes, because there is increased risk of ovary, colon, prostate apart from breast cancer. So these are there. In these cases, it's indicated. In this, it's not indicated because this is just like any sporadic case of breast cancer. Postmenopausal patient, age more than 50. So correct answer is A. Now see this question. Which of the following is true about the given image? Can you see this image? If you see the image, this flap, it is having only skin and fat, and it is based on perforator. After surgery, you can see muscle is not excised. So it is based on perforator containing skin and fat only. Muscle is not excised. Most probably this is DIEP flap. Deep inferior epigastric artery, perforator flap. So pedicle tram flap based on superior epigastric artery, no. Free tram flap based on superior inferior epigastric artery, no, because here we have to cut the muscle. DIEP flap based on deep inferior epigastric artery, yes. Lower abdominal flap based on inferior epigastric vessels, no. Correct answer is this one. And we discussed that tram flap, it is most commonly used flap. DIEP flap, it is best flap because we are not going to cut the muscle, so there is no weakness, no hernia. Now see this question, very important. Van Nuys grading system for ductal carcinoma in situ does not include. So what was the mnemonic? If you remember, it was micro swag. This was micro swag. Micro means microcalcification. Microcalcification. S, size of tumor. W, width of margin. A, age. G, grade. So you can see age, yes, size of tumor. Grading, you can see comedotype necrosis. So this is on the basis of grading. Hormone receptor staining, it is not included. So correct answer is C. So it is micro swag, microcalcification, size of tumor, width of margin, age of patient, grade of tumor. Clear? So this is micro swag. Correct answer is C. See this question. A similar question was asked in the past. Image shows methylene blue dye being injected into peritumoral region. This procedure is useful for. So this is sentinel lymph node biopsy. You can see here. In sentinel lymph node biopsy, we are going to inject the dye around the tumor, around the nipple, where exactly in areola. Clear? So what it is for? Localizing the tumor? No. Identifying the margin? No. Identifying the metastasis? No. It is for sentinel lymph node biopsy. So correct answer for this question is C. So this chapter is very important. I hope you enjoyed the session. This is all about breast.